All right, so the second and probably one of the most important parts of our personal characteristics unit is to talk about effective communication. So, communicating, we know, is an important skill, whether it's between peers, your patients, families, other professionals, and it allows us to be able to understand what another person is trying to say to us. So, the definition of communication is the exchange of information, thoughts, ideas, and feelings. We can have verbal, which is our spoken word, written communication, which some people do put under verbal, and then nonverbal behavior. So, things like our facial expressions, our body language, touch. It's important to keep in mind that a large percentage of communication is going to be nonverbal. So we have to be aware and pay attention to other people's facial expressions, their body language, um, their use of touch. So it's not just about the message that we're giving out. We want to be aware of our facial expressions and body language as well, but what the person we're talking to is giving back to us. So, we're going to talk about the communication process, which a lot of times is called the sender receiver model. And we'll see a picture of that on the next slide. The sender is the person who is giving the message. So, the person who's saying something, starting the conversation, trying to share an idea or thought. The message is the idea or thoughts that are being shared. The receiver is the person who is getting the message. And then after getting the message, the receiver is going to give feedback to make sure that they understood the message clearly or if the message was successful. That feedback can be either verbal or nonverbal. Again, think about our facial expressions or just making sure that we're on the same page. So if someone says, Miss Trask, could I change my seat? Maybe I hear that they don't want to sit as close to me as they are. So my response would be, why don't you want to sit close to me? Which is not the message that they were trying to convey. So my feedback showed them the message was incorrect or not received. And we would work on that communication to make sure that I was getting the correct message. So again, here we see just the sender receiver model. Sender is putting the message over to the receiver. The receiver is then providing that feedback to the sender to let them know if the message was interpreted how it was intended. We're going to talk about a lot of different communication factors. So, first of all, the message has to be clear, and that means it needs to be in terms or words that both parties understand. We've talked about this before, but if you're in healthcare, some of the terminology you're using may not be understood by people not in healthcare. So, we're going to make sure that we modify or use other words to make sure we're getting our message across. The example we have here is if you were to ask someone, I need a urine sample, they might not understand what you mean. So we may want to ask them instead, um, I need you to pee in this cup, because those are terms that are probably going to be just a little more clear than wondering how we're getting a sample of their urine. It does sometimes require a lot of practice to make sure that your message is being understood clearly. We also have to focus on our delivery. It needs to be clear, it needs to be concise. We want to use correct pronunciation. We want to use good grammar, and I know that's hard for some of us that are in texting mode all day. So we're staying away from slang words or words with double meaning. Try not to use filler, so things like okay, you know. Pay attention to the tone and pitch as well as the speed that you're speaking. I know personally that my tone is something I have to be aware of all the time, and sometimes I still don't do a great job. I also know that I tend to talk fast. So I have to be aware that I'm not going too quickly or speaking in a tone that comes across in a way other than what I intend. When we're using that written communication, we want to use our spell check, make sure that our grammar is appropriate, Keep it concise, so it's what needs to be said. I'm not giving them a whole backstory, just the pertinent or important information. When we look at the person receiving the message, first of all, they have to be able to hear it or read or whatever method you're sending it in. So if the patient is heavily medicated or in some other altered mental state, they may not or they may nod at you to say yes. That doesn't mean they actually understood the message. Remember, there is a difference between hearing and actually understanding. We'll talk a little more about it, but we also need to make sure we're considering visual and hearing impaired patients, as well as our patients or family members that have limited English speaking ability. So ideally, you want the receiver to repeat the message, change the form if necessary, or get others to interpret or clarify if needed. Remember, if we're using an interpreter, we're trying to use a certified interpreter, not just a family member. When it comes to understanding the message, like we said, using appropriate terminology is important. If we use a term that they don't know or don't understand, the message might not be interpreted in the way that we mean it. A lot of times people don't want to admit they don't understand something. They don't want to look stupid or look like they don't know what you're talking about. So as a healthcare worker, it's important that you have the ability to say, I don't know, but I'll find out. And again, make sure your patients are able to repeat the message back so that you can help make sure it's being understood in the way you intended it. We want to make sure we don't have any interruptions or distractions. If we're trying to multitask, like if you're trying to type something while you talk on the phone, if the atmosphere isn't appropriate, like it's too bright, too hot, too cold, that's going to mess up our communication because we're not focusing 100% on the conversation. When we listen, this means we're paying attention. We're making an effort to hear what the other person is saying. Hearing and understanding. We're not just hearing them, we're understanding them. And sometimes it takes a lot of practice to have these good listening skills. So we want to make sure we're not just hearing, but we're looking at them and observing for any actions or nonverbal language that might contradict what they're saying. So someone might say, I'm fine, but they're crying or wincing in pain. Those verbal cues or nonverbal cues are telling you that what they're saying verbally doesn't match the rest of the statement. We always want to reflect back, so this lets people know that we've heard them and gives them the opportunity to clear up any misunderstandings. So how do we be a good listener? Show interest and concern, make sure we're alert, maintaining eye contact if culturally appropriate. Don't interrupt. Don't think about how you're going to respond. It's okay to take a minute when they're done speaking to form a response. We have to try to get out of our own box. If we are immediately looking at it from only our lens, we're putting our own frame of reference and prejudices on what the other person is saying. So you have to be able to step outside of that and try to see someone else's point of view. Again, those distractions, move to a quieter place if needed. Watch for those nonverbal cues, and then reflect back and ask for clarification if you need it. There's no harm in saying, I just want to clarify, and then ask a clarifying question. Again, those nonverbal communication, facial expressions, body language, gestures, it, like I said, can convey a different message than what they've already verbally told us. So we just have to be aware constantly of our own verbal behavior and our nonverbal behavior. So eye rolling, it's not verbal, but it definitely conveys a message. When these verbal and nonverbal cues match up, then it makes it a lot easier to understand and receive the message. Now we're going to talk a little bit about barriers to communication, so things that can get in the way aside from any sender, receiver, or feedback difficulties. Things like physical disabilities, psychological attitudes and prejudice, and cultural diversity. So, looking a little bit more at physical barriers, a lot of times this is going to be relevant to deaf or hard of hearing in our blind or visually impaired patients. One thing we can do for our deaf or hard of hearing patients is use our body language, make sure we're speaking in short sentences, face them, especially if they're hard of hearing, write if necessary, and if they can read. Not every deaf person can read and write. If they have hearing aids, we want to make sure they're in and they're working. And then please, 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 an appropriate sign language interpreter if necessary. Don't just try to rely on writing. For our blind or impaired vision patients, we want to make sure that, first of all, we understand the level of vision impairment that they have. There's a difference between legally blind and completely blind. So they may be able to see the outline of your body language or your gestures, or they may not. We want to use a softer tone so we don't startle them. Make sure we are describing things that are happening. Announce your presence, so don't just walk into the room and then start moving around and scare them when you drop something. And make sure that we explain other sounds or noises or things that are happening. Aphasia is, notice it's aphasia with an S, so it's related to our speech, but it's the loss or impairment of the power to use or comprehend words. So people with aphasia, this is typically going to be after a stroke or other brain injury, are going to have a lot of difficulty speaking, and they may have difficulty writing. They also, imagine how frustrating this would be, may know what they want to say, but not be able to say it. They may not have the words, they may not remember how, they may have difficulty with the sounds. Their speech might be slurred or distorted, so it's important that we remember to be patient. Let them try to give their statement, ask questions that have those shorter responses. So don't ask for their medical history from the last 20 years if they're there for a stub toe. Make sure that you, as the provider, are speaking slowly and clearly so that they can form an appropriate response. Make sure you're pausing to give them the opportunity to make sure they're comprehending. And encourage the patient, don't rush them because it's going to make them more nervous, more embarrassed, less likely to be able to answer your question correctly. So psychological barriers tend to be things that result from prejudice, our attitude, our personality, things like being closed-minded, being judgy, being argumentative. This can include judgments of other people that are based solely on their appearance, lifestyle, and socioeconomic status, or how much money they have. We'll talk a lot more about prejudice and bias in another unit, but just for this, know that when we accept some of these stereotypes, like dumb blondes, it makes us more judgmental and less likely to give people the benefit of the doubt. We have to be able in healthcare to put all of this aside and treat everyone equally. For instance, we're not going to treat someone differently based on their gender or their hair color. We're not going to treat a victim differently than the person that committed the crime. Even though our morals may tell us that that person who committed the crime isn't worthy of getting their life saved, that's not our place to decide. We're there to provide them with equal treatment in healthcare. Cultural barriers, again, we'll talk about this more in our culture unit, but these are things like values, beliefs, and attitudes that are shared by a group of people. Culture is passed from generation to generation, and we might see it called a set of rules for a group of people. Within that given culture, it gives people the opportunity to kind of read the room, if you will, and behave appropriately as a result. It's not going to be uncommon for you to see certain cultures have beliefs and practices about health and wellness. So we always have to make sure that the patient has the option to determine and choose their own treatment plan. They can refuse care as long as they are informed. It's also a good idea, if you can, to try to incorporate some of those cultural beliefs with our traditional healthcare. So if you can get the patient to agree to see an acupuncturist and take a pain medication or see a physical therapist, then you're incorporating both of those practices but still respecting their beliefs. A cultural barrier we may come across is language differences. I hate that your book says this, but it says if someone is not English speaking, to speak slowly, use simple words, and use gestures or pictures. Now, if I go to France and I don't speak a lick of France, it doesn't matter how slowly they speak or how simple of words they use. I still don't understand French. So your goal is to get a certified interpreter, not a friend, not a family member. They may not know medical terms, and you don't know if they're translating everything you and the patient are saying correctly. When we give out any written instructions like discharge instructions, we want to make sure we give them in the appropriate language. For instance, again, if I'm in France and I go to the hospital, giving me discharge instructions in French is not going to help. Remember that eye contact might be considered disrespectful in some cultures. So if someone's not looking at you in the eye, don't necessarily assume they're being disrespectful. That might be their form of respect. Another thing we'll see that's different between cultures is how we deal with terminal illness or how we deal with severe disability. There are cultures that believe that a person does not need to be told about a fatal or terminal diagnosis. They shouldn't have to worry or carry the burden of making those treatment decisions. So the family will make the decisions for them. Now, in our system, unless this person's a child, this can't necessarily happen unless they have the appropriate legal documentation, like power of attorney for healthcare. But we have to be aware that there are going to be family members that don't think that you should tell the patient about specific things. And if that person's an adult, we have to make sure that we're giving them their rights to understand what their medical condition is. Sometimes use of touch is going to vary by culture, so some might find a handshake disrespectful. It really just depends. So make sure, for instance, if you offer a handshake and they don't take it, just move on. We have to be able to respect and recognize cultural diversity. We want to be able to provide transcultural care, which is where we're giving care that's based on cultural beliefs, emotional needs, spiritual feelings, and the physical needs of another person. Now that we've talked about the communication process and potential barriers, let's look a little bit about how we're going to record and report. So how are we keeping track of things? You want to write down everything. If it's not written down, it didn't happen. You need to make sure that you're listening to what the patient says, but also paying attention to any observations. We can use our senses to discover pretty much anything. So what's the color of their skin? What's the color of their urine? We know if our urine's darker, it usually means you're dehydrated. Do they have a rash? Do they have a sore? Do they have body odor? Does their urine smell like it's infected? Do they smell like alcohol? When I'm listening to them talk, do I hear that they're wheezing? Do I hear that their speech might be a little slurred and their family says it's not normally that way? We're going to make both subjective and objective observations throughout our assessment plan. So subjective are things that we may call symptoms. They're not seen or felt in the way that I can't physically touch the patient and feel a symptom. These tend to be statements or complaints that the patient makes, and when we're recording or writing them down, we want to put them in the patient's exact words and in quotations. So, for instance, if my patient says that they feel hot or that they feel dizzy, I mean, I could touch them and feel that their skin is warm, but I can't know that they feel dizzy. I can't necessarily see that. I can't feel it just by touching them. On the other hand, our objective observations, otherwise known as signs, are things we can see or measure. So I can see a bruise. I can measure how big it is. I can see a cut. I can physically take your blood pressure and I can check your temperature. So you might tell me you feel hot, but I can take your temperature and know that it's 102.5. One of those is measurable, one of them is not. A lot of places are moving to electronic health records or EHRs. So when I'm writing down or recording my observations, I want to make sure that they are accurate, especially if they are written in a written record. They need to be neat and legible or easy to read. Spelling and grammar needs to be correct. This is not a place where you should be spelling stuff wrong. Typically, we're only going to record our objective observations, so those signs that we can see or feel. Now, when you're doing your initial evaluation and your patient's telling you what happened or how they got that way, then yes, you're going to put some of that subjective stuff. Again, in quotations, in the patient's words. After you've documented it, you want to make sure you've signed your name on it. Sometimes this just means that you put your password in the electronic health record, and that's your electronic signature. Errors on written records, we need to make sure we cross out with a straight line. Write the word error next to it, and then our initials. Never do we try to erase or scratch it out or use whiteout. We've talked about HIPAA before. We're just going to touch a little bit more about how it relates to communication and records. So HIPAA has strict standards for how we maintain that confidentiality of healthcare records. Our patients have to have total control on how that information is used. And they have to be able to see and get copies of their records if they request them. They're also allowed to set limits on who can get the information and prevent other people from seeing it. My advice to you is always, if you go to the doctor and they ask you to fill out a form about who can get your information, if the answer is no one, put a big X across it. Don't leave room for anybody to go behind you and add someone to that form. Because of all these standards, if someone releases information without the patient's permission, they can be charged big fines. That's it for now. If you have any questions, please let me know, and I will see you next time.